Hello, 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 everybody. Good afternoon, good morning, and everyone between. Hello, how are you? Hi, thank you both so much for being here. I greatly appreciate it. Very excited for y'all to be talking with us today. We'll wait a few more minutes. It usually takes folks, you know, a good couple minutes to trickle in. So we'll wait just a few minutes for more folks to hop on. But I'm glad you guys could access the link to get on today. I'm so sorry about that oversight. Thank you for rattling our cages a little bit, saying, "Hey,
that's quite all right."
That's quite all right. And how are you both doing today?
Great.
Good.
At my age, every day is a good day.
Wait, say it one more time. I heard every day is good. What was the first part?
At my age, every day is a good day.
That's a good thing. That is a very good thing. Are you both in North Carolina?
Yes.
Fantastic. Well, I hear you guys are having just a little bout of nice summer, but not terribly hot weather right now, which is wonderful. I was talking with someone earlier. He said it was like 75 degrees, which is just beautiful.
With a lot of rain.
That's not good. That's not always enjoyable.
We need the rain. It's been very dry.
Oh my, well, that's a good thing. It's been dry here. And then Chip, who just joined us from Houston, I think is on the other end of the spectrum, where I'm surprised they're not completely burning up down there. I've heard it is hot right now in Houston. Is that right, Chip?
Yeah, it's like the face of the sun in Houston. So hot.
So I'm based in the Chicagoland area, and we have very standard summer weather here right now, you know, 85 and sunny. But I'm presenting at a conference next week in Las Vegas, and I took a look at the weather. It's a bit 110 degrees.
115. It'll be 115.
I can't. I just can't. I don't think I can leave. I think I'm just going to burst into flames the second you pick it up. You know what? I'm going to have to stay inside and gamble. I have no choice. It's for my house. I have to do that. I can't just be walking around out there. I'm kidding. Well,
but
so
it's
listen.
desert heat.
Yeah, right. Exactly. Right. You know, and as someone once told me, it's always 72 inside in Vegas.
Yes.
So, you know, anyways, well, listen, I want to be respectful of your time, and folks are going to continue to trickle in. But I want to give you a bit of an idea of who your audience is, and you're going to see folks just stream in here over the next few minutes. But we have a good mix of local office leadership, area managers, area directors, some regional directors, but we also have care managers here. This spans across the whole country. So we have Sade, who's in Riverside, California. We have Jen Beck-Schmidt, who is in Salt Lake City, Utah. Chip, who's in Houston. Beth, who you guys already know, is in the North Carolina area. Several other folks who are from the East Coast, so Florida, North Carolina, New Jersey. Micah, who's also from North Carolina. And celebrity, we have Ari, our CEO, who is now also joining. He's also based in North Carolina. So we have a good swath all the way across from local office leaders who are supporting our care managers and client services, as well as our direct care providers and our care managers. So a good mix of both. For you folks who are joining, this is such an important topic. As you know, our monthly care management meetings are really focused on education, and that education is to really help us live out our missions better. So how do we provide those superior models of care? How do we connect with as many clients as possible and support them? How do we walk a mile to build relationships? How do we live our missions and values? And what that boils down to is, how do we do our jobs really, really well and really be impactful? So when we're looking at racial injustice in the healthcare system, this helps us to better understand what some of our clients may be experiencing how we can better meet our clients where they are, and how we can provide that elevated care for them. This is becoming more and more a topic where we need to, at the very least, be aware of, if not focused on, as we continue to grow our referral sources. Our third-party referrals, those sources are increasing, which is fantastic, but that means we have a larger diversity in our client base, which is fantastic. So this is a very important topic. You all did not join to hear my voice, believe it or not. So I just quickly want to introduce our speakers, and then I would like for them to really help us better understand this topic. And I'm so appreciative to you both for being here. So quickly, let me introduce you. So Harold Barnett, raise your hand, do a dance, offer a smile. There he is. So Harold is an advocate for aging and health equity. He's a retired writer and consultant with a background in economic development. He's the author of numerous articles appearing in Shelter Force, which is the Journal of Affordable Housing and Community Building, as well as many case studies and essays that have been collected in anthologies by publishers like the Brennan Institute and Routledge Press. His work has won an Award of Excellence from the City of Atlanta Urban Design Commission, and he's the co-founder of the Institute for Family Caregivers Incorporated and co-author of The Caregiver Secrets, an account of the vital role family caregivers play in the U.S. healthcare system. Welcome, Harold. Thank you so much for being here. Now, Walitha King Barnett is the co-author of The Caregiver Secrets and co-founder of the Institute for Family Caregiving. She speaks, writes, and conducts educational activities on unpaid family caregiving. Walitha has spent 20 plus years as the primary caregiver for her mother while raising a child, working full-time and managing her own chronic illness. Insights gained from her experiences inform IFC's hands-on approach to family caregiver education and support. Walitha is a certified dementia practitioner and an annual guest speaker for first-year medical students during their GI rotation at a nearby public research university. She's participated in the NIA Impact Collaboratory and Alzheimer's Association's Lived Experience panel. Walitha lives and works in Durham, North Carolina. We have a few folks from there, where she has been long been a proponent for improving healthcare delivery and outcomes. Listen, my mouth could not keep up with every single thing that these two have done in their lives. I cannot thank you both enough for being here. Please take it from here. By the way, this is being recorded. Both Walitha, Harold, are you both okay with that?
Yes.
All right, very good. So I will share this with our local offices as well. So spread the word for anyone who can't be here. But for now, I'm going to mute myself and let y'all take it from here. Thank you.
Sure. Let me give a brief introduction. Walitha and I were once married in our 20s, back when people got married in their 20s. We have a daughter, a grown daughter who lives in Richmond, Virginia. I spent most of my career, well, if you want to call it a career, in the Atlanta area, although I had breaks where I worked in other parts of the country, and was retired there. Most of my background is in the private sector, working in housing, economic development related areas. Numbers kind of guy, but able to do other things. Our daughter, who was living in Virginia and working in a very pressure-packed corporate job, one of those executive positions where, you know, you got to make your numbers and all this sort of stuff, a lot of pressure. Her mother, who has had Crohn's disease for 40 years, was taking care of her mother, Queer's grandmother, daughter's name Queer, and things were getting dicey. I was aware of Walitha's chronic illness and the difficulties she'd had over the years managing it. When she took on her responsibility of caring for her 80-some-year-old mother, who had multiple comorbidities, I was a little concerned, but I figured it would work out. I've been healthy all my life, so I didn't really understand the inner workings of the healthcare systems and of the healthcare system, and especially now the elder care system. Well, what they call an elder care system in this country. So my daughter was driving back and forth, unbeknownst to me, up and down I-85 to try to help Willie to care for her mother. And she got to the point where she couldn't do it anymore. So she calls me, and I'm in Atlanta living the life of Riley. And she says, "Dad, I need your help." I said, "Well, do you want me to send money?" She said, "No, I don't need money. I need you to come here. I need you to physically come here and help us." And I was like, "Well, what is this about?" Because I'm not a person who's familiar with this kind of request. And so her plea was so urgent that I said to myself, well, this is probably something you need to do. So I packed the house up and left, and came to Durham, North Carolina, where I graduated high school, although I'm not from Durham. I spent the last couple of years of high school here. I went to 10 high schools in 12 years. And then I discovered all these things about people being older, people being sick, and people trying to take care of them. Belitha.
Yes. So it's interesting because I wasn't lived life of Riley, okay? As Jennifer, you were very kind in your introduction. Thank you so much for that. I was managing a demanding full-time job and the challenges of this chronic illness, as well as trying to raise my daughter when my mother started to have a lot of financial problems. She also had some health concerns. I'm the third of 4 children. I don't know how I got so lucky, but I'm sure that many of you understand that in many families, there is a chosen one, and we don't often understand why we are chosen. All right, I was the least able to care for my mother financially, but I am the one I'm a kin keeper. I'm the one in the family who says, we can't wring our hands. I have to do something. So since I couldn't exactly send my mother X amount of dollars on a monthly basis, I said, well, I'll just move her into my home. I'll move her 2.5 hours away into my home. She can help me with my latchkey kid. I can, we'll solve the financial situation, and everything would be okay. Well, it was hard. It was unbelievably hard. And I am of the opinion that things should not be as hard as they were. I learned a lot of things the hard way. Many people should be so lucky to have a Harold, an ex-husband, but a great friend, to kind of be willing to, upend his life and to come and assist. But Harold and I have always been friends. So he agreed to do that. It made things a lot easier for me, but not before I had basically emptied my 401k trying to take care of my family. It shouldn't be necessary. It's not something I recommend. If I had to do it all over again, of course I would assist my mother. I just wouldn't do it the way that I did. But things worked out. My mother passed away in 2016. I decided that all of the things that I learned, I could not set aside. So Harold and I decided Harold mostly, let's be honest, decided we should write this book. And I reluctantly agreed. And as, who is it, Harold, who says we thought that we would get together and form an institute? Harold
That'd be
pulled
Paul
that from the
Simon.
song. That would be Paul Simon, right? Let's get together and form.
Took it from an album by Paul Simon.
Yes. We should get together and form an institute. And we've kind of been on an adventure ever since. So that being said, let's get to the reason why we're here, Harold.
Well, first, I'm going to give a little primer, what I consider a primer on health equity, and then have Bolitha chat about briefly about the implications for home-based care, which we both believe is the direction that healthcare is taken in the future. It has no choice. I mean, there are fewer than what, 3 million combined nursing home and assisted living beds in this country. And there's 72 million boomers. So the math just doesn't work. The only place to find the beds is at home. So boomers are going to be taken care of at home. And so the whole healthcare system is going to have to restructure itself to make that possible. This is the physical reality faced in the healthcare industry. I say we because I've sort of appointed myself as a member of the healthcare industry. So disparities in healthcare requires basically understanding society. Our society changed. Understanding society requires understanding history. We're going to take as a starting point healthcare. The advent of modern healthcare dates from the end of World War II, which corresponds almost exactly with my lifespan. Most people don't realize that modern healthcare is a very recent phenomenon. So I was born just a few years after World War II. The first wave of my generation, the baby boomers. Okay, boomers get their name, of course, from the baby boom, present. GIs returning from the military conflict and the release of pent-up feelings from years of war restrictions and deprivations led to a lot of activity, which produced an unprecedented number of births. So this bulge in births has moved through the timeline between World War II to the present like a big meal through a snake. And we're now entering the phase, let's just call it digestion, social digestion, where elimination is the next stage. Over the next 20 years, nearly all of the 72 million or so boomers who are still alive are going to die. Just like their arrival announced a wave of unprecedented new life, their demise is going to signal unprecedented sickness and death. That's the reality we face. As the boomers, my generation, face this unprecedented die-off, it's useful to reflect on changes in society that have occurred over the course of my lifetime. I was born just after World War II. The US population was 85% white, 13% Black, and 2% other, which was a catch-all category for natives, Hispanics, and Asians. Today, my generation is still 72% white, 13% Black, and about 15% made up of other minorities. And that's due to deaths among boomers, immigration, and other factors. However, the society surrounding my generation has changed dramatically. Whites are no longer overwhelmingly dominant. Yet the culture of racial supremacy and exclusion that was created when they were overwhelmingly dominant still persists, although it's weakening. So this racial order was structural. No individual, it doesn't matter what people's individual prejudices are from a societal standpoint. Societies are shaped by laws and policies, shaped by government actions. So individual prejudice is not the determining factor in health equity. The social order is structural, it's embedded in law, in policy, and social custom. And this racial order shaped every aspect of society: economic opportunity, education, cultural matters, political participation, and of course, it shaped healthcare. The racial order that we're talking about, this racial social order, issued from and was enforced by every level of government, federal, state, and local. We're in the South. Jim Crow, when I was born and through my formative years, Jim Crow was the social norm in the South. I lived under an oppressive social regime that limited my possibilities as a human because of the color of my skin. There are 300,000 of us still living in North Carolina who lived under this regime. So modern American healthcare emerged as part of this social and cultural fabric. It was normal for Blacks to receive inferior healthcare if they received any at all. Research and innovations were targeted overwhelmingly at the white majority. Recruitment and training of doctors and other providers was focused on white people. With a few training facilities available to Blacks at segregated institutions. So this whole history accounts for today's comparative lack of Black doctors, technical specialists, executives, business owners, and others specialties in the healthcare field. In other words, the healthcare system that evolved in this country after World War II, essentially a healthcare system that catered to white people. And that has become problematic over the last several decades as American society has changed dramatically. The society has lost its overwhelmingly white composition. Today's society is much more pluralistic due to the growth of the country's varied non-white racial and ethnic populations. The racial and ethnic basis of the current system is being exposed in mainstream organizations like the American Medical Association. And this is prompting calls for deep reform and an emphasis on healthcare equity. So this is where the whole emphasis on healthcare equity is coming from. It's being driven by demographics. And the demographics are irreversible. This is not going back to what it used to be. What's coming is going to be very different from what was. And I'm happy to say that good people like you are part of that change, and you're structuring and driving that change. It's a very important role. So as the delivery of healthcare services becomes more decentralized and home-based, due to a lack of institutional beds, as we've said, the system will have to adjust to dealing with the very racial and ethnic diversity it has been able to ignore in the past. It is this shift to home-based care that holds the possibility, in my view, for driving real reform and equitable performance in healthcare. But that's far from guaranteed. If the future of healthcare has any hope of transforming into a fair and just system, this shift to care in the home will have to be predicated on a deeply restructured and reformed system that offers equal access, treatment, and opportunity for all. I sent a few references over to Heather, articles and research that I think might be useful to some of you in understanding the complex demographic and policy issues that are bound up with health equity, and I hope that this conversation can continue. Waleetha is going to talk now about some of the specific home care matters that relate to this.
I just have a few comments. I hope that based on anything that we say, that you all will feel free to ask us questions, which I think will be much more useful to many of you. I'd like to follow up on Harold's comments by saying that the shift to home-based care services is multiracial, multi-ethnic population. And that is creating a daunting challenge for a healthcare system rooted in discrimination and racial exclusivity. Here's the thing. When patients go to a hospital or clinic or other institutional setting for care, they adjust to the procedures and protocols of those facilities. On the other hand, when healthcare personnel are sent to the home, whether in person or via technology, their institutional culture is not really effective. They must adjust to the unique family and cultural circumstances of that particular household. In other words, the basis of healthcare delivery is turned upside down. Successfully navigating a multicultural population will require a multicultural approach to healthcare delivery. Now, we think that family caregivers are the link to making this transition. They are the key interface between provider and the patient in securing improved healthcare outcomes. That's why IFC, the Institute for Family Caregiving, coined the mantra, providers are the experts on diagnosis and treatment, caregivers are the experts on the patient. So it will take many years for the healthcare system to achieve the kind of diversity that reflects the population that it will be serving going forward. Now, in the near term, family caregivers can be that cultural bridge to cultural penetration, customizing care, and achieving better outcomes. So with that being said, we thank you for your invitation and your attention. And again, we welcome any questions about what we have said or our own personal experiences.
What do you guys think? Who's got some questions or has had any kind of experience where there's been a little bit of inequity, or and maybe, you know, for some of that inequity can have to do with maybe based upon the type of insurance or where you live. You know, I have found just depending on where a person lives, whether it's rural versus urban or a certain area, there's limited access to healthcare resources. Have you guys experienced anything like that? Yeah. I wonder, when you're in a situation where you have a client who's experiencing any source of, or any kind of inequity, what's kind of the next step? Who has some experience there, and what have you found successful?
I like to share something.
Yeah.
That goes back to reinforce my comment about this not being a matter of individual attitudes. There's this emphasis on social determinants of health, but many determinants of health are structural.
Mm-hmm.
And they're embedded in the system itself, the healthcare system itself. I have a geriatrician, an extremely diligent and capable young white doctor. I love her to death. But when she changed one of my few medications, she was worried about an impact it might have on my kidneys, so she ordered a kidney test. When the test came back, I went online to my online medical record, and I noticed that there was a racial designation in front of my test result. And I knew from reading that there were adjustments made to the data to come out of these tests for Black people that resulted in about 1 out of every 4 Black persons being undertreated as a result of the manipulation of the data from the test. And I brought this up to her. I said, look, did I get the colored test? And she dropped her head. This woman is not a racist. She is an employee of a huge healthcare system that continues to use a test that they know has disparate racial outcomes. So when we start talking about health equity, we're not talking about bad behavior necessarily on the part of individuals. We're talking about practices and protocols and tools in the healthcare system that produce these disparate outcomes.
So Harold, in that situation, it's our job to fight for our clients and to advocate for them and to be sort of their voice when they either don't know something is happening or don't have the strength or understanding or desire to fight for themselves. So the resources that you provided us, does that give some examples like you just shared of, testing or healthcare related issues that we might encounter where we want to fight on behalf of our clients? Is that included
Absolutely. There are cases where individual behavior, for example, my parents were both double amputees, but I have a very strong history of diabetes in my family on both sides. Luckily, I've avoided it, but some of my younger siblings have not. It's very clearly documented that Black diabetics 3 to 4 times greater chance of suffering amputation than white patients. The therapies that work on white patients that to avoid amputation work equally as well on Black patients. It's well known that these therapies work for everybody, and doctors are free to use them to reduce the necessity of cutting off limbs. But in Black communities, you find all these people with severed limbs because the physicians don't take the time. They aren't interested in going through all of the rigmarole to repeatedly do these intravenous operations that are required to remove plaques from inside the blood vessels. So they just decide to cut the limb off. And you have communities in this country, Black communities in this country. When I say Black communities, I don't mean integrated communities. I mean communities where 80 to 90 to 100% of the residents are Black that look like war zones. People have so many severed limbs that they walk around on prostheses and on crutches and canes and other mobility aids, simply because their doctors have hacked off their legs. So this is the kind of thing that patients need advocates to avoid. This kind of negligent and really abusive, surgery. And this is across the board in many cases. In heart disease, Blacks don't get the same kinds of preventive and interventionist procedures that can make their lives better and prolong their lives. And the literature, none of this stuff is a secret. The research is done, it's empirically verified. It's available for anybody who wants to look it up and know it. None of this is a secret. Many of the causes of health inequity are rooted in the system, in the practice of medicine, and in the way that healthcare is distributed. Lack of access and difficulty of access and other issues.
I wonder, thinking about that just one scenario that you talked about with amputation, have you found at all, because this also guides how we advocate, have you found at all that any of those alternative treatments to avoid amputation, and you could then transpose the same question to a lot of other treatments and issues, but in this particular case, those alternate treatments or alternative treatments, are they not covered as readily by insurances? And so then they're avoided because there's a whole pre-authorization process that goes with it that wants to be avoided. And then second question, are those alternative treatments, have you ever found any cultural connection to where they're not as accepted? Have you seen either of those scenarios, or it's just plain and simple not discussed with them and it should be?
I'm not an expert on it. I know let me recommend this article in ProPublica that addresses the issue of disparate amputations. Yeah. And there are references in there that can inform those of you who are really in the industry as to how all that stacks up. You can actually find the answers to your questions in looking at these case studies. But let me give you another example. The American Medical Association in the last few days came out with an announcement disavowing BMI as a health measure.
Woo-hoo! All right. No, I'm kidding. And
it's
Go ahead.
long been known that BMI is a specious measure of health. It wasn't even invented in a healthcare setting. It was invented, it was made up by a mathematician. So when I look at my BMI number in my medical chart, I just laugh because I'm 6 feet tall. I have broad shouldered and I'm of a muscular build. And my BMI indicates that I'm overweight. My waist size in my 30s was 34. I'm over 70 now. My waist size is 36. Any fool can look at me and see I'm not overweight. But my chart reflects that I'm overweight. And so from a medical decision-making standpoint, the chart dictates. So you have all this erroneous information about people in their charts that doctors are making decisions on, and the information is not reflective of their health status. So these are the kinds of things that are really problematic within the healthcare system that need to be addressed. And the healthcare system doesn't like to change because all of its business models, and I'm a numbers guy, well, like I said, all its business models are based on what it's doing now, because what it's doing now is highly profitable. So they don't want to change what they're doing now.
Mm-hmm. Thank you. Yeah, and I look forward to that that article because I mean, listen, we're warriors to some extent. You know, we are happy and proud to go to battle for our clients to make sure that they have all the information needed to make an informed decision. And in some cases, we're making medical or healthcare decisions on behalf of our clients if we're authorized to do so. So having that information will be great. You know, I wonder if we can also, there's another component here that as an organization, we have the responsibility to consider, and that's how to support our own teammates, our own caregiver office teammates, and their access to health information. Do you have any thoughts on how, as an organization, we can make sure that that's certainly prioritized and done well?
Rifa?
I think it's important that we advocate for each other. And it's difficult to do that if we're not aware of whatever challenges, without going into, deep detail that someone is facing. I don't see it as being remarkably different from what family caregivers do. All right. I thought that oftentimes my mother was in pain. She didn't necessarily have the words for what it was she was trying to get across to her medical providers. So I made a habit of going to my mother's appointments with her. It was partially for her protection. It was for my own information. It was to make sure that she was being treated well. I have my own examples, okay? My mother was referred to an endocrinologist for essential hypertension. Very difficult to control her high blood pressure. So we went to this large healthcare system to see this provider that she had never seen before. My mother was hard of hearing and not very compliant with wearing her hearing aids, okay? So I knew that. Another reason for me to go with her. The provider came into the room, barely looked at my mother, immediately turned to his computer and started talking to her without facing her. Now, my mother had a tendency to read lips, okay? So she was kind of lost in the discussion. So he asked her about her readings. When he came in, she tried to give her readings to him. He declined to accept the piece of paper, which was my first red flag. He said, well, just tell me what your readings are. And she told him they were high, which was the reason that we were there. And then he said to her, taking your blood pressure should not be a hobby. My mother didn't know what to do with that response. It wasn't a hobby. She took her blood pressure frequently because she could tell from her symptoms that her blood pressure was elevated. So So second kind of red flag. So she proceeded to give him additional information. Then he interrupted her and asked her if her diet consisted of Vienna sausages and lots of fat back or things like that. At which point my mother broke down, crying, because she knew she was being disrespected. Since we were there about her blood pressure, my interest was in ending this conversation. All right. It was no longer in her best interest to continue with this provider. He got up and left the room. I immediately started thinking about what I could do to really help in this particular situation. So I asked the nurse to come in. Her idea was that we see a different provider. My interest was in doing something in this particular situation to make sure it didn't happen to other people. He knew nothing about my mother. She was very literate. She had no problem with the language. I was offended as well. So I thought to myself, what is the most effective way of dealing with this? So I asked to see patient relations. But in the meantime, my mother got sick. Her blood pressure skyrocketed, to a level that would indicate that she was at risk for a stroke. So the person came from patient relations. Her recommendation was the same. Let's see if we could get your mother to see a different provider. That wasn't good enough for me. I am the kind of person that I'm really not interested in arguing with providers. I wanted to do what was going to be the most effective. I went home, I wrote up what happened, and I sent it to the person responsible for the emergency department, responsible for endocrinology, and the president of, my thing is, don't just do a lot of talking. Send this to someone who is able from the top down to do something about this. I felt better, my mother did not. Months later, when my mother was admitted to the hospital, this doctor came into my mother's room and apologized. I thought that was pretty remarkable. Don't know how he knew she was an inpatient, but we appreciated that. So that's, as a caregiver, as a family caregiver or a paid caregiver, I'm not sure, that the interactions are really so very different. The intentions are the same. We are there as advocates more than anything else. All right, for those people who might not have the words or the language, or they're not paying, they're in pain, they're not able to communicate effectively. And I think that as employees, you all can, you can advocate for each other. You run into scenarios where you could, you can help each other just by sharing without even mentioning names or anything like that. I've learned a great deal that way.
Yeah.
Also, if I may,
Mm-hmm.
there are some very specific things that folks in your position can do. Number one is advocate for people getting training to be able to access their training and other support, technical support, to access their online medical records. There are lots of errors in medical records. And as quiet as it's kept, there's recent research that indicates medical errors may be the fourth leading cause of death in this country, after heart disease, cancer, and COVID. COVID actually moved it down one notch. And then medical errors, because medical records are full of mistakes. And doctors do not know their patients these days. You know this very well. Doctor gets spent like 15 minutes with a patient. They run them through there like cattle through a chute. And they're relying on a record that may be filled with mistakes. false numbers, inaccurate numbers. For example, these scanning technologies, the temperature scanning and the blood oxygen scanning, those technologies do not work. They're not calibrated for dark skins. What happened in COVID is that Black people would take their folks to the hospital and they'd be gasping for breath and be seriously ill. But when they scanned their finger with this technology, it then accurately, in many cases, indicated that they had blood saturation levels that were adequate. And they sent those people home, very often to die. In the healthcare system has been calibrated for white people. And with all of these people of color now in the population, that just ain't working. So we just have to back up and begin to realize that the population that we're serving going forward is not the population that a lot of these technologies and a lot of these procedures and protocols were developed for.
And is that true of any skin tone that is not white? Does that extend across the board, or is that really specific to Black skin?
Well, I know that it's specific to Black skin, but the research hasn't been done. I mean, the industry isn't really interested in doing the research because they aren't interested in recalling and redoing their instruments. But this is something that needs to be looked into. And people absolutely need to have the capacity to go online and read and understand their medical records. I mean, it's outrageous that this responsibility for their medical information is being exported to them, but they're getting absolutely no support in being able to access or comprehend what's in there.
Well, not only that, but you know, if I'm trying to think when it was, April maybe of 2021 or 2022, it was not a law, but providers were encouraged to provide access to their narrative about the patient, the notes in the medical record. That has not always been the case. You could see your lab results, you could see all the profile information, but you might be able to see some things that your medical provider said. But now it is definitely the case that information that your doctor dictates to someone is actually available to you in your medical record. So again, Harold, I'm just saying, I would encourage everyone to have access to medical records. I had access to my mother's medical records, and people say to me, how in the world did you do that? Well, right or wrong, I knew her password, okay? So I wanted to keep a close eye on that.
Well, and I think that's okay. Actually, Walita, that was the next thing I was going to say. With consent from our clients, you know, we have authorization consent forms for access to information. We are able to access those electronic records on their behalf. I mean, we have to have that consent to do so. But with that in place, I often, for clients, have sort of been their go-between, where if they don't have access consistently, or the inclination or the know-how to be able to access those records, we can maintain those on their behalf. You can always request printed out records before you leave. So can I please have the record of today's visit before leaving, and you can keep a record that way. I think it's important, you know, I no matter the situation, part of what we do and what we have to do well is collecting all information and then verifying understanding of our clients. So, you know, let's say, for example, I'm in a doctor's appointment, and, you know, let's say a physician makes a recommendation for a kidney test, like you yourself had, Harold. The questioning really needs to be, is this the only option? Are there other options? What information do you hope to obtain from this test? Are there any risks of this test? Is there any sort of risk of inaccurate information coming out of this test. What is the cost? Where is it? Like you need to get all the information, then review it with your client again and make sure that they understand so that they can really make an informed decision. Protecting that ability to make an informed decision is so much of what we do. And we're also lucky because we have nurses available to us as well that we need to be utilizing, like Jen Beck-Schmidt that's on this call, like Nicole Holloway. I'm trying to think if we have any other nurses. And we actually are working to grow a clinical consultation availability within our own company. So, let's say I go to an appointment with a client and there is medical implications or risks or testing issues, and I myself don't have the answer. I can say, you know what? Let me go connect with Jen Beck-Schmidt. Let me review what's going on. Let me get her take on this as a nurse, and then let me come back to you, or let me facilitate you speaking directly with her. So I do want to make sure that everyone on this call knows that we have access to clinically, medically trained teammates who we need to be utilizing more often to evaluate, or even I've even connected with nurses in the past saying, listen, I've got this upcoming appointment with a client. What questions do I need to make sure that I ask the doctor? Use these folks. They have additional clinical training, just as they may reach out to us if there's a mental health issue that they want more information about, or something of that nature. Again, not always, but it's available. So as we wind down a bit here, I think I always like to try to end with some takeaways. And I think it's the takeaway I'm hearing is make sure that you are educating yourself. Review these resources that Harold and Walitha have provided. Make sure you're educated on, I guess at the very least, the potential of racial inequity within healthcare. And maybe that is inadequate access to healthcare, or maybe it's perfectly adequate access, but it's access to testing, for example, that could have racial implications. So there's still a disparity there. And then also the education piece is educate yourself on what questions to ask, and then what to do next, as Walitha beautifully highlighted a warrior story. If you feel that your client is not being given adequate access to healthcare, what do you do? I don't know. I don't always know the answer, but I know the answer is not sitting there grinning and taking it. I know that. It's our job to do more than that. So I think if I had to pick takeaways, it's that. We need to educate ourselves, both on what we know, but also what we don't know, and what our clients do and don't know. What do you think, Harold and Walitha? What about, takeaways? Did I miss anything? What do you think? If you want us to leave here knowing nothing else but this, what would you think it should be?
I would say that it's the importance of your role. Look, press, you guys do, because your role can really make a massive difference in the outcomes for many of your clients. But you have a big job, because number one, you're fighting an ignominious history that is attached to healthcare in this country. For example, in the Black community, there are always there's a legacy there, and there are always rumors circulating that makes people rumors that make people distrustful of the healthcare system because of the history that is objectively bad. And then you're dealing with a healthcare system that's in the throes of really serious structural change. So you're having to deal with this onerous history, and then also a system that is in flux, and the rules and guidelines and other controlling factors are changing almost daily. So I think that you guys are really important, as a kind of buffer for the client vis-a-vis a system that is really difficult to comprehend, not just access it, it's difficult to comprehend. And I admire the work you're doing, and I admire that somebody had the vision and foresight to organize an enterprise like this.
I would just like to say, that's great, HB. I would just like to say, if hopefully having the name of a caregiver, a family caregiver, is something that is entered into your system. I say that because there are many things that happen in the intimacy of the home that are not always revealed. But these things are important in terms of healthcare outcomes.
Absolutely. Yes, that I could not agree. I think most of us on this call, and you know, a great deal of our assessment and evaluation and support process focuses on that living environment and support system that's available within the home and the immediate family, because that can truly make or break outcomes for clients. So, well, this is fantastic. I appreciate you both so very much. This is a huge topic. I appreciate you bringing it to our attention and giving it the spotlight that it deserves. If we have additional questions, or if a situation arises and we'd love some expert advice, do you mind if we reach out to you in the future if the need arises for that?
Absolutely.
Sure, we'd be happy. And shout out to
Great.
Beth Reeves.
Isn't she
For
fantastic?
mentioning us.
I mean,
you, Beth.
she deserves 1,000 shout outs. If for no other reason, then I mean, what a fierce warrior advocate. I mean, there within our very own Beth Reeves. I mean, she is always looking for ways to be more impactful for folks, like bringing this very topic up, saying, we need to hear this. It helps us be better. So thank you, Beth. I appreciate that. So
yeah.
All right. Well, we will have all this recorded. We'll share it with our teams. Letha, Harold, thank you so much for being here.
Thank you.
And I wish everyone well and a fantastic rest of your week. So thank you all.
Take care, everyone.
Bye,
Thanks so
everybody.
much. Have a good day.
Bye.
Thank you. Bye.